Chronic red facial rash. Letter of referral. Dear Dr. Miss Julie McGinty, aged 25 years. Thank you for seeing this primary school teacher with a 2-month history of a red facial rash. It has not responded to multiple treatments, including antibiotics and topical steroids. I would be grateful if she could be seen soon as the rash is deteriorating. Her students are making comments and she is increasingly psychologically affected by it. Yours sincerely. Introduction. A red facial rash is a common dermatological scenario. There are many common and rare possible causes, which can often be distinguished by a good history and examination. Common causes: atopic eczema, contact dermatitis, allergic or irritant, seborrheic dermatitis, psoriasis, acne, rosacea, perioral dermatitis, acneiform type eruption often induced by topical steroids. Less common causes: systemic lupus erythematosus, SLE, discoid lupus erythematosus, DLE, dermatomyositis, tinea faciei, sarcoidosis, photosensitive eruptions, exogenous and endogenous. It is important to remember to ask exactly what has been applied to the skin, both as a cosmetic and as a medicament, as these can cause problems with both irritancy and allergy. Topical steroids can also cause their own side effects of acne, perioral dermatitis, and telangiectasia. It is vital to explore the psychological impact of the rash on the patient, particularly when there is facial involvement. History of the presenting problem. Does the rash itch? Eczematous rashes such as atopic eczema or allergic contact dermatitis, ACD, tend to itch more than other eruptions such as acne. Fungal infections also itch. Did you have eczema, asthma, or hay fever as a child? A flare of atopic eczema could be the diagnosis, or it could possibly be an associated irritant contact dermatitis on a background of atopy. What do you wash your face with / apply to the skin? Soaps and foaming facial washes will all irritate the skin. Facial wipes, cosmetics and medications may be a potential cause of ACD. Topical steroids, and inhaled steroids, can induce acne and perioral dermatitis. Do you develop pus-filled spots within the rash? Acne, rosacea, and perioral dermatitis may all be associated with pustules. Do you flush easily? This is a classical symptom of rosacea, but is not exclusive to this condition. Does sunlight make it worse? Cutaneous lupus and dermatomyositis are both aggravated by sunlight. Photoallergic contact dermatitis, chronic actinic dermatitis and photosensitive drug eruptions can all flare in the summer months. Is the rash anywhere else? Other relevant history. General health, SLE, dermatomyositis, and sarcoidosis may all have associated systemic symptoms. Classical examples are SLE associated with joint pains, mouth ulcers, hair loss, and Raynaud's phenomenon, dermatomyositis associated with proximal muscle weakness and symptoms of an underlying associated malignancy, and sarcoidosis associated with cough, shortness of breath. Family history: psoriasis and atopic eczema have strong familial links. Drugs: many common drugs may cause photosensitive eruptions, e.g. thiazides and tetracyclines. Psychological impact of the rash: the psychological impact of a visible skin condition is often underestimated and may have a dramatic impact on a person's quality of life. A chronic red facial rash examination. General features. As ever, Take time to survey the whole patient before homing in on the face. A patient with atopic eczema might have additional involvement of the flexures and have asthma inhalers on the bedside cabinet. A patient with dermatomyositis may have involvement of the hands with additional nicotine staining, providing a clue to the underlying etiology. NB. When examining a patient who you are told has a localized skin problem, it is vital to examine the whole skin, including the scalp, the nails, and mucous membranes. There may be hidden diagnostic clues. Cutaneous examination. Key points to look for include the following. Facial skin. Look for any papules, pustules, and open comedones, blackheads, which are classical signs of acne. Rosacea can look similar to acne but is not associated with comedones. Severe rosacea can cause an enlargement of the sebaceous glands on the nose, rhinophyma. Is there any scarring? This is important with respect to planning management in acne. Scarring also occurs with discoid lupus erythematosus, DLE, but not with systemic lupus erythematosus, SLE. Determine if the distribution is in keeping with photosensitivity playing a role, e.g. exacerbation of SLE, dermatomyositis, or photoallergic contact dermatitis. Look for sparing of photoprotected sites, e.g. under the chin or behind the ears, Wilkinson's triangle. What is the distribution of the rash? Is involvement localized, e.g. DLE, sarcoid and tinea faciae, or is it more diffuse, e.g. eczema or SLE? Is the rash scaly? Eczema, psoriasis, DLE, and tinea will all cause scaly eruptions. Acne, rosacea, and SLE are generally not scaly. Trunk and limbs. What is the distribution of the rash? Acne may be most severe on the chest/back. Rosacea usually only affects the face. Psoriasis may look atypical on the face but have classical plagues at elbows and knees. Flexural involvement of the limbs is typical of atopic eczema. Dermatomyositis and sarcoidosis could affect other sites. Nails. Look for any signs of psoriasis, pitting, onycholysis or subungual hyperkeratosis. Look for the presence of nail polish, a common cause of allergic contact dermatitis on the face. Hands. Search for any signs of dermatitis, e.g. scaling in finger webs associated with irritant contact dermatitis. Look for Gottron's papules and or nail fold inflammation indicating possible dermatomyositis. Photosensitive eruptions classically affect exposed skin on the dorsum of the hands and the face. Scalp and hair. Is there any scarring, inflammation, scale and or hair loss? If alopecia is present, determine if it is diffuse or localized, scarring or non-scarring. Scalp scarring is identified by a change in texture of the skin and a lack of visible hair follicle openings, and in this case would most likely be due to DLE. If scale is present, determine if it is thick and silvery, as in psoriasis, or more like dandruff, as in seborrheic dermatitis. Is the patient's hair dyed? Hair dye allergy commonly presents with facial eczema. Examination of other systems. Examination of other systems may be appropriate, e.g. musculoskeletal examination in dermatomyositis and joint examination in psoriasis. Further discussion. Causes of red facial rash, clinical findings. Atopic eczema. Erythematous scaly rash, often affecting eyelids. Generalized cutaneous involvement, particularly of flexural sites. Contact dermatitis. Erythematous scaly rash, particularly affecting eyelids. The distribution may be unusual, failing to conform to that of an irritant and allergic endogenous eczema. Seborrhoea dermatitis. Erythematous, greasy scaly rash affecting nasolabial folds and eyebrows. Other sites often involved include scalp, anterior chest, and axillae. Psoriasis. Erythematous scaly localized areas on face. Frequently associated with scaly rash on the scalp, particularly at the scalp margins, nail changes, and scaly plagues at extensor sites. Look for psoriatic arthropathy. Acne. Papules, pustules, open and closed comedones, blackheads and whiteheads. Look for associated scarring, cysts and nodules. Examine the chest and upper back. Rosacea. Erythema associated with papules and pustules. No comedones. Look for rhinophema. Is often associated with flushing. Perioral dermatitis. Papules, pustules, and erythema affecting a localized area around the mouth. May also affect periorbital skin. SLE. Classical malar erythema, butterfly rash. Non-scarring. Other features may be present, e.g. Raynaud's phenomenon. DLE. Inflammatory, scarring and well-defined oval scaly plagues. Follicular accentuation within. May be associated with scarring alopecia. Can be mistaken for psoriasis, but there is usually limited involvement on body in cases of DLE. Dermatomyositis. Heliotrope, violet, discoloration of the eyelids, periorbital edema, nail fold inflammation, and Gottron's papules / streaking along dorsum of fingers, and ragged cuticles. Sarcoidosis. Blue and red papules and plagues infiltrating the nose, lupus pernio. Red and brown papules and plagues. Systemic disease may be associated. Photosensitive eczema. Eczema as above, with a photoinduced distribution, i.e. dorsum of hands, V of neck and the face, with sparing of covered sites. Ensure that you are familiar with the clinical features of SLE, dermatomyositis, and sarcoidosis and know how you would confirm the diagnosis if one of these was suspected. It is difficult to diagnose the cause of facial eczema / dermatitis on examination alone. In practice, patients often have a mixed etiology for facial eczema, e.g. a background of atopic eczema that predisposes them to irritant dermatitis caused by facial washes, and in turn possibly causes an allergic contact dermatitis to a medicament or fragrance, only discovered when patch tested. Plan for investigation and management. Investigations. Perform a full cutaneous examination, including hair and nails, to make a diagnosis and to assess the extent of the condition. Then proceed to examination of other systems depending on the diagnosis, e.g. musculoskeletal examination in psoriasis and full systems examination in SLE. Consider the following. Patch testing if ACD is suspected. Skin scrapings for mycological examination if tinea faciei is suspected. Skin biopsy if SLE, DLE or sarcoid are suspected, or if the diagnosis was uncertain. Blood tests, e.g. FBC, electrolytes, and renal, liver and bone function tests if systemic disorder is suspected. Other specialized tests as clinically indicated, antinuclear factor, anti-double-stranded DNA, and extractable nuclear antigens for SLE and DLE, angiotensin-converting enzyme levels for sarcoid, and creatine kinase levels and 2 more markers for dermatomyositis. CXR if sarcoid or dermatomyositis is suspected. Management. Management should include general advice to avoid irritants on the skin such as soap, facial washes, cleansers and toners. Wash instead with a soap substitute, a bland emollient such as aqueous cream. Specific management varies between conditions. Table 3. Follow-up in outpatient clinic, time interval depending on condition, where you can review with results and start treatment and or assess response to initial treatment regimen. Further discussion. Patients often ask if it is safe to apply topical steroids to the face. It is important to provide reassurance that they are safe if used sensibly, with respect to the potency of steroid being applied and the length of time of application. Low-potency steroids used in the short term, several weeks, or on an intermittent basis to control disease, should cause very few problems. In the long term, the continuous use of potent steroids can cause many side effects, including acne, skin thinning, telangiectasia and cataracts.